Hello, I'm Dr. Mark Gorman from Boston Children's Hospital and Harvard Medical School, and I'm pleased to talk to you today about diagnostic challenges in pediatric autoimmune encephalitis. I have no relevant financial disclosures for this talk. My goals for this talk are that by the end of it, you will know the major causes of encephalitis in the pediatric population. Secondly, you'll be aware and be able to start to apply published diagnostic criteria in adult and pediatric autoimmune encephalitis. And finally, to appreciate some of the challenges in the diagnosis of autoimmune encephalitis in pediatric patients, focusing on two current major topics in the field. One, psychiatric predominant presentations, and two, the role of anti-myelin oligodendrocyte glycoprotein, or anti-MOG antibodies. To help illustrate some of these points, I will start with a patient story. This is a patient of mine that I helped to take care of about 1 year ago. The patient is a 17-year-old female with a history of, quote, anxiety, who presented with decreased interaction and difficulty speaking. This occurred in the setting of several recent school and social stressors. Over the course of 2 to 3 weeks, the patient became withdrawn, had new difficulty memorizing schoolwork, had a change in speech, which became low volume and was described as halting, and then had intermittent biting of her lip, which the examiner felt was suppressible. Following an episode of staring and decreased responsiveness, the family brought her to the emergency room. On exam, the patient indeed appeared withdrawn. She had halting speech and had frequent lip biting and mouth movements, which she was able to suppress for 1 minute when asked and or distracted by the examiner. A brain MRI and EEG were performed, and both were normal. So with this story in mind, I'll pose the question to the audience. What do you think is the correct diagnosis? Is it an anxiety disorder, autoimmune encephalitis, drug intoxication, or infectious encephalitis? So I'll pause here and you can mull over the diagnosis and think about what you think is most likely and what you might do next. So in the real world setting, the patient was diagnosed with anxiety and discharged from the emergency room. However, she worsened over the next few days, and so her parents brought her back to the emergency room. At this point in time, a more detailed cognitive assessment was performed using the Montreal Cognitive Assessment, or the MoCA, and she scored a 17 out of 30, well below normal. And this was compared to her baseline, where she was an honor roll student. With the progressive worsening, as well as the evidence of cognitive dysfunction, a lumbar puncture was performed and had 46 white blood cells, of which 95% were lymphocytes. So we'll go back to the question, what's the correct diagnosis? Is it 1, anxiety disorder? It seems very unlikely now, particularly in the setting of the lumbar puncture results. Is it 2, autoimmune encephalitis? Certainly possible, and we'll keep that on the list. Is it 3, drug intoxication? Again, very unlikely in the setting of the lumbar puncture results. Or is it 4, infectious encephalitis? We'll keep it on the list, but it seems less likely in the setting of having no fever or other infectious symptoms. So this patient clearly has encephalitis, and I think it's worthwhile just to think about what are the broad diagnostic criteria for encephalitis. This is a case definition that's taken from the California Encephalitis Project, which was a landmark study in the field in the 2000s, and really set a great framework for encephalitis research. In that study, they defined encephalitis as encephalopathy, meaning the presence of altered mental status, plus at least one of the following: fever, seizure, focal neurological findings, CSF pleocytosis, or EEG or neuroimaging findings consistent with encephalitis. The last element there being a little bit of a circular definition. So our patient meets this criteria. She has altered mental status and also has CSF pleocytosis. As we look more closely, and one of the objectives of this talk is to know the causes of encephalitis in the pediatric population. This slide here shows 4 different major case series spanning from 2006 to 2020, showing the various causes of encephalitis, both in adults and children, in the first 2 studies and in pediatric population, specifically in the second 2 studies. Overall, and what I quote to patients and families, is that approximately 1/3 of patients will have an infectious cause, 1/3 of patients will have an autoimmune cause, and 1/3 of patients will have no known cause identified. As you'll see in the slide, the percentage of cases attributed to autoimmune encephalitis has significantly increased over time, going from 3% in the California Encephalitis Project to anywhere from 21 to 34% in the other studies. This is attributable to 2 things. One, the bottom 3 studies included acute disseminated encephalomyelitis and also included patients with antibody-mediated encephalitis, given that the technology and discoveries had evolved such that these could now be diagnosed. And although historically our field has focused on infectious causes of encephalitis, it's become clear over the past decade or so that autoimmune encephalitis is at least as common as infectious encephalitis. This was rigorously proven in a study from the Mayo Clinic, where they did a population-based study looking at the incidence and prevalence of autoimmune and infectious encephalitis. And these were not significantly different between the 2 entities. In addition, the incidence of autoimmune encephalitis tripled from 1995, 2005 to the following decade, 2006 to 2015. And this could be directly attributed to new antibody discoveries. So when faced with a patient in the emergency room where you have your history, you have your physical exam, and you may have some additional tests, but you don't yet have the antibody results, when can we suspect the diagnosis? This is a landmark paper in the field from 2016, the Grouse et al. Criteria, which recommend trying to make a diagnosis of at least possible autoimmune encephalitis even before antibody results are available. And our patient meets these criteria. So she has the subacute onset of less than 3 months of short-term memory loss. She did indeed have difficulty memorizing her schoolwork, altered mental status, or psychiatric symptoms with social withdrawal. And you also need to have at least one of the following: new focal CNS findings, seizures not explained by a previously known seizure disorder, CSF pleocytosis, which our patient checks that box, or MRI features suggestive of encephalitis. And then finally, you need to reasonably exclude alternative causes. Following this paper, several of us in the pediatric community recognized that there may be some challenges in applying these criteria to the pediatric population, and this could be for several reasons. One, the pediatric nervous system is still developing in terms of circuits, receptors, myelination. In addition, the presentation of autoimmune encephalitis in the pediatric age group overlaps with other diseases, and the differential diagnosis differs somewhat from that in adults. There's also the complexity of normal behavioral changes. We can appreciate that in our patient's presentation with mood changes in adolescence during the COVID-19 pandemic. Certainly, we were all seeing patients who did not have autoimmune encephalitis presenting with that. And so we need to think carefully about how can we discern which patient does indeed have autoimmune encephalitis as the cause. Particularly younger children will have limited ability to describe their symptoms, especially the cognitive and psychiatric symptoms compared to adults. And so we're reliant on both parental observations as well as our own observations during the exam. And finally, there are some differences in symptoms, paraclinical findings, treatment response, and prognosis. With that in mind, we developed pediatric specific criteria. On this slide, we won't go through it in great detail, but just to be aware and reference back to this paper when you're seeing a pediatric patient with possible autoimmune encephalitis. And it goes through different levels of diagnostic certainty in terms of possible, probable, and definite autoimmune encephalitis. And this algorithm also walks you through your thought process when facing a patient with possible autoimmune encephalitis and when to consider various levels of testing. So within the space of pediatric autoimmune encephalitis, what antibodies do we find? Far and away, the most common are anti-NMDA receptor antibodies, and as we'll see in some later slides, anti-MOG antibodies. Less common are anti-glutamic acid decarboxylase antibodies and anti-glycine receptor antibodies. Beyond these four antibodies, while certainly there are case reports or small case series of other antibodies involved in pediatric autoimmune encephalitis, they are all exceedingly rare in clinical practice. We will today focus on the two most common autoantibodies in pediatric autoimmune encephalitis. So going back and thinking about our patient who's presenting with what seem to be predominantly psychiatric symptoms, how can we pick out which patient has autoimmune encephalitis versus a primary psychiatric disorder? This study specifically, on this slide, specifically addressed when patients are presenting with a first episode of psychosis, which our patient does not have. But I think nonetheless, this study is useful in thinking about this diagnostic challenge. So this study was done by the Dalmau group, and they did a prospective observational study of 105 patients with a first episode of psychosis, and they assessed all of them for serum and CSF neuronal antibodies with several different techniques, including brain immunohistochemistry, cell-based assay, and live neurons. This was predominantly an adult study with a median age of 30, but it did include adolescents with a range of ages from 14 to 75. So our patient would have at least entered based on age criteria here, and 42% of this cohort were female. In this study, none of the patients had neuronal antibodies. And at the end of the evaluations, 96% were diagnosed with a psychiatric disorder. 4% were diagnosed with a non-psychiatric disorder, which included one case each of frontotemporal dementia, HIV, hyperthyroidism, and metabolic derangements. But as you see, none of the patients were diagnosed with autoimmune encephalitis. Thus, it can be quite challenging to try to decide which patients who are presenting with psychiatric symptoms may actually have autoimmune encephalitis. This is another algorithm proposed in that paper, which suggests tests that could be done when patients are presenting with a first episode of psychosis. And in those patients who do not have additional neurologic signs, they propose starting with serum neuronal antibodies, EEG, and brain MRI. And if any of those are abnormal, then to go on to CSF testing. In our patient, I would propose that in fact, she did not have a psychiatric-only presentation, because when we look at the history and the exam more closely, we see that she actually had language dysfunction, with a clear change in speech. And she also had clear changes in her cognition, with difficulty memorizing her schoolwork, and a significantly poor performance on bedside cognitive testing. So I think it was appropriate that in this patient, she underwent CSF testing, and thankfully that led to the correct diagnosis. So, of course, we want to go more specifically than just a broad diagnosis of possible autoimmune encephalitis. And the Grouse et al. Paper also proposed diagnostic criteria for anti-NMDA receptor encephalitis. And if we apply these criteria to our patient, she's very close to meeting criteria. So she has the rapid onset of 3 needing, and these criteria propose needing 4 of the 6 following major groups of symptoms. I'm going to go back a bit and restart the slide. So, of course, we want to be more specific in our diagnosis if we can, than moving from possible autoimmune encephalitis to a more specific antibodies if we can. So in the Grouse paper, they also proposed diagnostic criteria for anti-NMDA receptor encephalitis, which can be applied even before the antibody results are available. Our patient almost meets criteria. These criteria call for having 4 of 6 major symptoms, while our patient has 3. So she has abnormal psychiatric behavior and cognitive dysfunction. She has speech dysfunction. And I also think she had a movement disorder, specifically orofacial dyskinesias, which are well described in anti-NMDA receptor encephalitis. In our particular patient, these were initially misinterpreted as being a symptom and sign of anxiety with lip biting, but on closer inspection were actually orofacial dyskinesias. She does not have seizures, a decreased level of consciousness, or autonomic dysfunction, with the last point there being that children and adolescents are much less likely to have autonomic dysfunction or central hyperventilation than adult patients. She also has at least one objective abnormal laboratory finding with the CSF pleocytosis. And just to make another point in terms of what's fluids to send in order to test for anti-NMDA receptor antibodies, serum is certainly easier than CSF, but in most cases where you have a high suspicion of the diagnosis, both should be sent. Overall, it appears that serum is about 85% sensitive compared to CSF. So how do these criteria perform when applied to pediatric patients? The Grouse paper was really designed initially for adult patients, but as it turns out, the anti-NMDA receptor encephalitis criteria perform quite well in the pediatric space. So Russell Dale's group did a retrospective validation of these criteria in a cohort of 29 children with anti-NMDA receptor encephalitis and compared them to 74 children with other forms of encephalitis, which included ADM and infectious encephalitis. In this group of 29 children, 90% of them, of those with anti-NMDA receptor encephalitis, satisfied the criteria, and that was compared to only 4% of controls. And that led to a sensitivity of 90% and a specificity of 96%. So overall, quite good performance, even in the pediatric space. And the median time to fulfill these criteria was 2 weeks. So it was a relatively rapid evolution of symptoms. So let's go back to our patient. Of course, we want to think about other differential diagnoses, and in particular, think about infectious encephalitis. Our patient's presentation was not totally suggestive of that, and that she did not have fever or other infectious symptoms, but we did do a PCR for HSV and enterovirus, the 2 most common infectious causes of encephalitis in pediatrics, and those were negative. So even before we had the antibody results in hand, we treated her empirically with high-dose intravenous methylprednisolone, along with intravenous immunoglobulin. And with that, she had improvement in her speech and cognition. Knowing that about 40% of patients overall have an associated tumor with anti-NMDA receptor encephalitis, we performed a tumor screen with MRI of the chest, abdomen, and pelvis, which was negative. And then following discharge, her antibody results came back and confirmed the clinical suspicion for anti-NMDA receptor encephalitis, with serum and CSF antibodies being present. So in fact, although she was initially diagnosed as having an anxiety disorder, her correct diagnosis was anti-NMDA receptor encephalitis. And I think paying careful attention to some of the clinical clues in our patient, the cognitive dysfunction, the orofacial dyskinesias, can help us pick out patients who may have autoimmune encephalitis despite a psychiatric predominant presentation. So take-home points for this section of the talk: in pediatric patients with encephalitis, about 1/3 each are due to autoimmune, infectious, and unknown causes, respectively. Diagnostic criteria for adult and pediatric autoimmune encephalitis are useful, and they have good performance, especially with anti-NMDA receptor encephalitis. Finally, quote-unquote, psychiatric-only presentations are likely very rare, as shown in the Daumel study, but we really, as clinicians, need to make sure that these presentations are truly psychiatric-only and pay careful attention to speech, language, and cognition. I'll shift gears now to a second patient story, and this patient and slides are courtesy of my colleague Coral Stredney in our neuroimmunology program. This patient is also a 17-year-old, previously healthy girl who developed right temporal headaches, which woke her out of sleep without any other associated symptoms. A few days later, she had a severe headache, and then later that day had 2 seizures, characterized as left head turning, arm stiffening and shaking, and then post-ictal left facial weakness. And she was admitted to the hospital with confusion, lethargy, and ongoing right temporal headaches. A lumbar puncture was performed, and she had 78 white blood cells with 89% lymphocytes. So she meets criteria as well for encephalitis, given the new onset seizures, mental status changes, and the CSF pleocytosis. This was her brain MRI, and here we're looking at an axial flare sequence and then an axial T1 post-gadolinium sequence. And we can see on the axial flare images that there is flare hyperintensity in the cortex, particularly in the right posterior region. And on the post-contrast images, we see increased contrast enhancement along the leptomeningeal space on both sides, but predominantly on the right side. So what do you think is the most likely diagnosis here? Is it acute disseminated encephalomyelitis? Is it anti-MOG antibody-associated disorder? Is it small vessel CNS vasculitis or viral encephalitis? You can think about which diagnosis you might make. Indeed, her diagnosis was anti-MOG antibody-associated disorder, and her serum anti-MOG antibodies later returned positive. She was treated with IV steroids and an oral steroid wean, but as is common in anti-MOG antibody-associated disorder, with weaning of the steroids, she had a recurrence of symptoms, very interestingly now on the opposite side, with onset of left temporal headache and right hand dystonic movements. She was now started on IVIG and restarted a slower steroid wean. She's now symptom-free with a stable MRI on ongoing IVIG, although her anti-MOG antibody remains positive. And this was her MRI from her second presentation, shows similar findings as to the first MRI, However, this time now in the left hemisphere. So what is the role of anti-MOG antibodies in pediatric encephalitis? This was clarified by a very comprehensive study from Thijs Armand and Joseph Dalmau, where they looked at 239 children with demyelinating syndromes and 296 patients with encephalitis. Within the demyelinating cohort, not surprisingly, anti-MOG antibodies were positive in 39% of the patients, and that had been shown previously in other cohorts as well. If we look more closely at the subgroup of patients with encephalitis, 34% were found to have an infectious cause, again with enterovirus and HSV being the most common. 22% were autoimmune, and 45% had no known cause found. And here was the somewhat surprising finding. So of those with autoimmune encephalitis, 34% had anti-MOG antibodies. And this was a higher percentage than anti-NMDA receptor antibodies, which were found in 22%, which previously was thought to be the most common antibody in pediatric encephalitis. 11% had other antibodies found, and then 33% had other types of encephalitic syndromes. We look at the 116 children with anti-MOG antibodies. 59% had clinical features of encephalitis. Within that group, 68% fulfilled diagnostic criteria for acute disseminated encephalomyelitis. However, 32% did not. So the take-home point here is that anti-MOG antibodies can be present in children with an encephalitic presentation, even if they don't have findings suggestive of acute disseminated encephalomyelitis. So we really need to think about anti-MOG antibodies when seeing a pediatric patient with encephalitis. So the take-home points of this second half of the talk is that although classically associated with demyelinating syndromes such as ADEM, optic neuritis, and/or transverse myelitis, anti-MOG antibodies can also cause encephalitis. And so I would urge you to strongly consider sending anti-MOG antibodies in all pediatric patients with encephalitis. Thank you very much for your attention, and I look forward to fielding your questions in the question and answer session.